Greece from the University of Munich.
And I'm thankful to be here in India again. And I said always, for us, the Greek is like a holy dream to come in this country, because we know very well from your ancient history how much we have influenced our mythology and our history. So I think that is very important always to understand this, let's say, connection between these two countries in the level of culture and history. So of course, but cornea cuts, because in order to use the femto technology today to make any type of cornea transplantation, the cornea has to be very clear. So in other words, today, I think the parental democracy is known the most successful tissue transplantation. And if you go back to the history of that, the last century, the beginning, we had the first successful transplantation by Edward Zern. And then 1930, we have a square and round grafts at the same time, and with different types of cards. 1950, we developed and we used the first time with the 890 40 years ago. I was thinking to do custom fascination in order to correct the cylinder. In this study, what I found at the time, I found that when you cut around the recipient, the opening never is round. It has a strange shape. But I found that this shape is always very much related to the Placido configuration we had before. So using the Placido at that time, I could predict somehow the shape of the open cornea after the destination. In this sense, you can predict somehow that time should be, let's say, this customized donor. Of course, the time was not a way to think about femtos or have this technology to, let's say, personalize your card within. So I think that the major problem we get up to now in this type of surgery is the post-operative astigmatism, either regular or irregular. The source of astigmatism very often is a misalignment of lateral surface between donor, partner, and posterior. Never they have the same thickness, and it is also not easy to suture and pretend, let's say, the one by another relation. We have some rotational misalignment also. We have uneven suture tensions, so you have to be very good researcher to have already the same tension in your suturing. We have also the wound healing, which is post-operative, somehow is very slow, and generally also an astigmatic healing. So this problem is arising for corneal definition technique, for suture placement, for unstable dimension of the graft, and we have also to define the donor from endothelium using the punch blood stain, and from epithelium needs to be mounted the graft in artificial anterior chambers. So the corneal incisions, which today probably are proposed, which are multi-level of thick corneal incisions, they are proposed in order to improve donor and post alignment, to increase the good stability, to decrease the need for high surgification to support the graft. And this incision is initially proposed by Franceschetti and George in 1951. Parakeet also proposed much earlier and we're possibly have less astigmatism. So the ideal path for me is to lock the donor with the recipient cornea, which means you have to have vertical side scars or oblique side scars to achieve faster and better healing with lower failure risk, and if possible without getting procedures. So the last one probably is a dream, did not get achieved, but probably sometimes specific design we can do that way that we don't need procedures anymore. So thinking of that, I was thinking we have this type of card, the N card, which is this is the shape of the card. And here it does the drawings, how it looks like. It's like, let's say, a vertical Z type of card. And the major, I think, importance of this card is that this is not running parallel to the surface, but it's going up here. So means the here is any type of angulation when you block, let's say, the donor on the recipient. So you can do that today, at least in my clinic, it was possible with the wave-light chemical laser. You can see here how nice you can precise do this type of cuts. You can change any parameter, of course, on the electron microscopy. Here are the principles, how it works. The end cancer can not only prolong here the cornea better, but also in that way made that you can use the edge of the donor here to guide it precisely in the future in the deep end of the recipient, which means you can really have a one-by-one relation at least of the anterior part of the cornea. And when the pressure in eye rises a bit up, down, you have this type of biomechanical effect. In this case, it has been as the pressure is higher, you look much more and much better the donor and the recipient. And again, the suturing here in this case is very easy to do and very easy to be controlled under the microscope. So this technique of course allows us to make symmetrical our suture, and as I said, the need to pass always at the same depth. And we've done 3 cases up to now, and I'd like to see the first case we've done. It was a 31-year-old patient with bilateral keratoconus. He has on one eye, I think he has to go ahead ventricular topography, a traditional one, and this was the left eye. I was looking before the surgery, figure counting, left first, figure counting, and was related to the with the NCAP. So we kept together a couple of problems to be sure we've done the apex to concentrated application with this system for the NCAP, and we use the parameter system anterior chamber for the graft penetration. This is the anterior chamber, the artificial one we use to touch the donor, and you will see here in the video how it works. It's very easy. This is the graft design on the way screen, so you can see the same time, but the vision was not something about the other eye a few years before with the conventional keratosis. So I think this is the balance of the system, and I think it's, I have to say longer that we have better done, of course, pairing the related complications for malignant better stability, less regular sequencing, faster application, and using our experience also with our patient. The positive step back in these technologies are kept to remove probably the internal structure to change. We need to remove a lot of chromophilium, and with that one patient probably not the best way to go, but there is a matter of course of the residual amount of research. So I would like to stay here and thank all of you, and I hope we can find something going and enjoy. Thank you very much.
Thank you very much, Professor Barikari. That was really wonderful presentation. I'm sure that will certainly make keratoplasty a far easier and better procedure utilizing your new research. Thank you so much. Our next speaker is Dr. Daljit Singh. I just say a quick hi to Joe Vakil, my friend, the one who had done a lot of work on corneal topography and whose machines were used long ago. Joe, hi. Dr. Daljit Singh needs no introduction. Having said that, the inventor literally of intraocular implants in India, the one who has done outstanding work on the Daljit lens. I think by now probably 10 lakh units have been implanted in India. He's done outstanding work as far as the entry segment is concerned, and since the last 3 years has been working on his new system of lymphatics, which he has shown apparently work extremely well. Dr. Daljit Singh, we look forward to your presentation. You have 15 minutes for a presentation which will actually take 3 hours, but 15 minutes is what you have. Sir.
Good afternoon, everybody. One sentence on congenital lymphatic. And what you are looking at are lymphatics which are not supposed to exist. And if there is some pigment at the limbus, you will see this lymphatic network beautifully. Professor Margot of Switzerland, Chairman and President of the International Council of Hematology, says that it's amazing that all the ophthalmologists of the world did not see them. My presentations have been plenty, and it has been published in the book also. And you can see the channels from the cornea going towards the penicillin, and you see all the rivulets being drained away. You have the history of both calycid for the last 100 years. And these are nothing but lymphatics. When you do optical section, you will find that they are tubes. And these calycids are connected to the cornea with the network of channels in the cornea also. And these calycids are connected to the congenital lymphatics. And in between cornea and congenital, you have lucidant dermal in the cornea, which is also a channel. When there is fierce congenital hemorrhage, the lymphatics going towards the limbus get filled up with blood. And my work started in 1999 by a chance observation. I injected nicotine at 11 o'clock, and instantly a lymphatic vessel rises at 2 o'clock. Then I inject triple Q and was able to find the network of lymphatics. And since then I have been hunting and shooting lymphatics. And in the operation theatre, if you twist the congenital along the limbus, you will always see lymphatics running parallel to each other. And you can also see lymphatics by injecting triple Q at the limbus. It should work.
Somebody might in the dust.
Yes. So I have charted in dozens of patients, and this was my first one. And you can see that an injection at the limbus will chart all the congenital vessels of the in the neighborhood. And this patient had trauma and dislocated lens and glaucoma. I did microtransplantation before removing the lens. The next had damaged conjunctiva on the limbus, case of vitreoretinal surgery, and I injected dye into the sclera, and it rose a number of knobs along the limbus because there were no vessels over there. And the surprising thing was that where the conjunctiva was normal, the lymphatics received the dye from the sclera. That means there is a connection between scleral vessels and the conjunctival vessels. And they all exist from the cornea as single channels, then they join with each other and then join with the conjunctiva. Sometimes they look like mushroom, depending upon the angle at which they issue from the sclera. And you see that they are in multiple layers. It's not just one layer, multiple layers. And so there are multiple layers of channels in the cornea, and intermediate there is the lucid interval, I will show you later. And they come out in multiple layers and join together into a multiple layered conjunctival lymphatic system. And after surgery, glaucoma surgery, if there is a failure and you try to mark out the lymphatics, you will fail to do that. That's why you try to look for a virgin area for doing filtration surgery. In this patient, because of multiple surgery, most of the conjunctiva is scarred. So I find one area where there is no scarring, and I do a simple operation. I just push the conjunctiva towards the limbus and use a plasma plate and make 2 tracks into the area containing the aqueous. And doing that, I do not injure the lymphatics of the conjunctiva. Here's another one. This is my latest technique, that I make a vertical incision in the cornea and use pupil blade to make a track from ab interno. A 300 micron tip just goes to the limbus and opens under the conjunctiva. So there is no damage to the drainage system of the conjunctiva. This is all the operation. It takes about 3 minutes to do. So now we have a closer look at the limbal area. You see these channels in the cornea, and you have that area of the lucid interval. And this is the lucid interval. Sometimes you get such beautiful pictures. You find that the lucid interval is not like a line. It is so irregular because of the channels which are connecting from the corneal side and from the conjunctival side. This was a patient with megalocornea and cataracts. We did cataract surgery and found an opacity in the center, and we magnified it, and we found that there was a network of channels in the cornea. And on optical section, these channels are found inside the stroma. And then if you look at patients with prominent arcus senilis, an old patient, you will always find these channels which you call as crocodile shagreen, which has no meaning at all. These are channels, and that's why they are there. There is another patient, she has channels all over the cornea. And this one is after cataract surgery, very severe keratitis, and you would say that these are folds in the descemet membrane. That is not true. These are the channels which are draining the excess fluid in the cornea, and these are the stromal channels. And then there must be finer channels which you will find in non-specific keratitis. These are the micro channels. And you look at any optical section, histology section of cornea, and you will always find these channels in the cornea, and they are always labeled as artifacts, just because they do not know that lymphatics exist. Now these cornea surgeons, they make a big corneal bubble and lift the cornea, and this lifting is possible just because there are channels in the cornea, and you push air into the corneal channels, and they get lifted because the descemet membrane doesn't have any channel. So you cannot balloon something which is solid. Air, yes, and when you inject the air, you make a big bubble and look at the periphery. You will always find that the lucid interval contains that air. Now this is a very interesting case, very prominent lucid interval and very prominent arcus senilis. And when I go closer, I find that the edge of the arcus senilis looks rough, and when I magnify it further and find that these are the channels from the cornea into the lucid interval, and they are there in multiple layers. And on optical section, the lucid interval will appear as triangular with the anterior and posterior wall, and you will find it is connected to channels towards the center of the cornea. The first time I saw dye that was long time back, I injected dye into the cornea to mark the conjunctival channels, but I found dye in this area, which is the lucid interval. I have been able to pass 100 micron blunt wire into the lucid interval a number of times, so I don't need to do again and again. But a wire cannot pass into the channel, into an area which is not a channel. And I can pass a 230 micron cannula into the lucid interval. And this you have already seen. Now, what I am going to show is that when you inject dye in the lucid interval, this dye moves preferentially towards the center of the cornea. That means this could be a source of nutrition for the cornea and not merely the endothelium. And maybe this is the major source of nutrition. On optical section, I sometimes find that the lucid interval area is connected to canal of Schlemm area through aqueducts. And this is happening all over. It's not uniform, and you do not see it every day, but you see it frequently. Now, if you use pilocarpine, sometimes you find that on the optical section, one area of the lucid interval becomes more prominent. And this is a very prominent case. Had an angle fluid glaucoma, I gave pilocarpine, and 24 hours later you find that the lucid interval is prominent and the aqueducts are prominent and they are connected to canal of Schlemm. So this is the picture that you have the lucid interval as a central artery which is collecting fluid from Schlemm's canal, and it is pushing fluid into the cornea and pushing fluid into the conjunctival lymphatics. Our corneas are highly reactive, all because of lymphatics. In the small corneal abscess, and you find so many cells in the cornea, and on optical section the cornea is full of cells. Just 2 days later, under intensive treatment, you find that the cells have disappeared and channels have appeared. Channels determine disease pattern. So you will find in many infections, especially fungal infection, radial spread, circular spread, and spread like satellites. And all these changes are occurring in the middle of the stroma. And network-like spread you often find in fungal infection, just like that. And channels of many mysteries. For example, this is a case with oblique hypopion, very strange. And under intense treatment, next day you find that the hypopion has shifted vertically, and it has gone within 24 hours, it has reached 12 o'clock position. That means the infection is passing through. And you see this very fast spread. The fast spread will occur only because of the presence of channels. Corneal nutrition comes mainly from the periphery. Once you have a ring abscess and a ring ulcer, the nutrition of the center part of the cornea suffers and nothing can save it. That means periphery is more important for nutrition than just endothelium. Channels help in diagnosis and treatment. This is a young patient who came with infiltrates in the area of lucid interval. I look at 6 o'clock, there are satellites. Around 3 o'clock, you see number of satellites going upwards for 12 o'clock. So prognosis grave, reduction was needed. So this is what I did. I opened the whole of the lucid interval, injected antifungal, antibacterial into the lucid interval, injected antifungal, antibacterial into the cornea, and then this is the final result. She recovered. Then there was a patient patient who had been under treatment on for 6 months elsewhere and he would not heal. I looked at the ulcer and saw that the lucid interval was infected. Now, unless you treat lucid interval, this ulcer is not going to heal. So this is what I did. I opened the lucid interval and treated, and he soon recovered. In acute glaucoma, why there is edema? It is because the fluid is pushed from Schillem's canal via the connecting this whatever it is into the cornea, and the cornea becomes irrigated. The moment you do filtration, the cornea becomes clear. You see this in the case of acute glaucoma, I am doing transciliary filtration into the posterior chamber, and the moment the fluid starts coming out of the channel, the cornea becomes clear. Just like that. So this would not happen if endothelium was responsible for the control of fluid from the anterior chamber into the cornea. So it is the movement, mass movement from all over, from the Schillem's canal into the lucid interval canal into the cornea that causes edema, and once you reduce the pressure, and immediately the fluid moves out. Okay, and the limbal allergies are connected with lymphatics. You see that, we see them every day. So, all I want to say is that the corneal channel, the lucid interval, the scleroungual channels, connective lymphatics, they are all one system and need to be studied like that. Thank you very much.
Thank you very much, Dr. Daljeet Singh. So very kind of you. We have come to the end of our session. I'd like to thank everybody, including the speakers, for keeping to their time. And we'd like to thank the All India for the opportunity of being with them.
Factor in ectasia development. Dr. Rohit Shetty is the Chief Consultant of Cornea in Narayana Nethralaya, Bangalore. He has the passion for corneal dry eye and etiological factors in ectasia development. That is his passion, and he has done a lot of research in this field. And I am sure you will enjoy his talk and his thoughts on etiological factors in ectasia development. Dr. Rohit Shetty.
Thank you, sir, and thanks for this wonderful opportunity to share etiological factors of keratoconus. That's why it's very exciting. Disease has been described close to 150 years back. By definition, if you really look at this, it is a non-inflammatory, usually bilateral corneal disease. The genetic association of it. Unfortunately, it's got a multifactorial variance. So genetics earlier, I'm talking about 15-20 years back, was not really conclusive. Let me start with the study by the FLEX study, which is probably one of the most important landmark study in keratoconus is concerned. It showed a 14% in that group. They also had the study, which is in 2008, which looks at siblings, not siblings, the first degree relatives of people with keratoconus. And it found that significant amount of them, I'm not saying statistically, but they do have some changes on the topography which was done. If we have to study the genetic mutations in these cases, which are the genes which we look for? VX1 mutation in the families, sorry, the mistake here. Deletion of the SOD1 gene, and these are the factors which we look for. What the areas I am working on in the Indian population, which we also have an ICMR grant now, is working on the VX1 mutations. We feel that many of us, patients who have genetic mutations as just mutations, so if you're looking specifically in Indian context, this is one mutation which you look for. And if we are able to find a good association in the population a year or 2 years from now, then this could be a marker for keratoconus and also a marker to figure out whether the first degree or the relatives can have this disease. Many studies have looked at many genetic associations from 2 to 70, but we have had families, these two families I worked on, which were putting which is predominant in the population which we have studied. So if you're looking at one gene, it's a VX1 gene. I mean, maybe very early in the day, but still, the early results say that it's a 30 probably in our population, and VX1 gene which is probably need to look at. It's got multiple associations with syndromes, from connective tissues to low mental functions, and they are being listed out here. It's been associated with retinitis pigmentosa, glaucoma, multiple things. What really actually, we may all harbor genes. It's like harboring the genes for lung cancer. As long as you don't smoke, probably may not develop it. But when you start smoking, probably the same gene can mutate. So the environment factor plays an important role in the triggering of a disease. To look at the environmental factor here, it's first atopy, eye rubbing, and probably leads to corneal ectasia. That's the usual trend, but it's a very simplistic method of trying to denote this whole thing. What really causes it? Multiple studies have been done. It's got association with asthma. Flex studies have big association with hay fever, but we need to understand the population they looked at is completely different. And more patients with atopic symptoms than in the normal patients. So the question is it really related to the eye rubbing? It's difficult to answer because it's been so classically drilled into our mind that eye rubbing and ectasia is so common. Many studies do support that. This suppose that it's an eye rubbing, probably the atopy or the related to that. One interesting paper which I found in the American Journal of Ophthalmology here, 84, very old journal, but it's very interesting. This patient had atrial tachycardia and his sinus ridden. To get his sinus ridden, to reduce his ocular cardiac reflex, he had to virtually use one eye to press one of his eyes. And that started developing keratoconus. And when they actually told the patient that you can press his carotid sinus instead of his eye to correct arrhythmias, that stopped. It was one of the first papers which looked at eye rubbing as a mechanical factor for causing the keratoconus. And this amount of pressure you use when you are rubbing your eyes, that also makes an important factor here. The amount of force what we give here and the amount of force when you use a knuckle is completely different. So more pressure you give probably reduce more chances of it. So if you're looking at that as a mechanism, what are the factors which causes this? Probably increase the temperature by rubbing the eyes. It's a pressure, hydrostatic pressure, whether it leads to an enzymatic activation. And all these other factors of how you activate or change the protein levels in your tears. Hormonal changes also plays an important role because many times because of puberty, predominance in females, estrogen is known to be a hormone. We all know that there's a progression of keratoconus during pregnancy, and this is one of the factors where hormonal changes can also play an important role. Coming to the most important part of the work on keratoconus, and also one of my areas of great interest because it happens to be my PhD work is inflammation in tears. Many inflammatory mediators have been known. In this thing, you're looking at the interleukin-1 family, because this is one which looks at many areas of changes in different parts of the body. How does it actually work? A change in the epithelial trauma, living trauma, microtrauma induced by changes apoptosis of the cells. These apoptosis itself can play a role. And they are also increased in cells which are in the keratoponic eyes, so this shows that there could be a change. There has always been a question mark about when contact lenses. Patients wearing long-term contact lenses, there have been times we have known that an RGP lens itself can show a progression. It's a very old study, not something new, but it does show that inflammation during contact lenses can also induce an IL-6 and plays an important role. Now we know that there is some inflammation things happening, then how do you know what inflammatory mediators play a role? So what we started looking at, one of our studies was, we started looking at multiple markers of inflammation. The multiple markers, we know one which is commonly studied is an MMP9. It is a very non-specific marker. It's easy to study because you have available kits in the market because the dry eye is such a common area of MMP9. When we actually look at the MMP9, it actually changes with the stage of keratoconus. And the first question which comes to your mind is, did these patients have dry eye? The answer is no. None of them had any dry eye. We had evaluated for all the methods of trial testing. The second question is when the contact lens users, they were not contact lens users, they were the patients who came to us freshly detected keratoconus of different grades. It took a long time to do this. We jointly worked on this project with the SNDC Roger Government in the Sphere Lab, and we found that it actually matches with your grade of keratoconus. That means that something happening there which is not just a non-inflammatory path. The pathway here is definitely an inflammatory nature. And also, we started taking the tears and started analyzing the tear proteins. Most of them I can't even know the full names of it, but trust me, all of them have different pathways, can cause inflammation and changes related to inflammation. Each of this have upregulated in these patients with keratoconus. That means these proteins may have a different role of inflammation on the stromal or the corneal level. So that means to say that MLP9 and many inflammatory proteins are upregulated. So we need to look at keratoconus in a different way. And what we normally do is we used to take the tears, we used to preserve it in our eyes and send it to a lab, which looks at analyzing these proteins. And it's just it's one of the first kind where we isolated a bunch of them which are very specific to the inflammation. And you can see from here that most of the proteins, TNF alpha, IL-6, MLP9s, everything is much, much higher compared to patients who are having low keratoconus. So what we are trying to see here is, if we are looking at an MLP9s, IL-6, IL-2, TNF alphas, there are multiple areas of intervention at the medical level itself. That means that if you are trying to look at each one of those proteins, you'll be surprised that the cyclosporin can block an MLP9 and it can also block a little bit of IL-6. So time to come when we analyze and go deeper, all the known methods of keratoconus what we have can be probably arrested at this level itself, at the protein level itself. So what are the molecular signaling pathways we looked at? The most important signaling which needs to have an inflammation upregulated, the groups which are responsible for keeping a balance of health with the cornea is downregulated, and there's a complete scheme of inflammatory and signaling pathways which actually tries to create an imbalance in this process. I'll just take a minute and I'll stop, because what happens is one of the foundation of a collagen, or how the collagen is binding, lies in the lysyl oxidase or LOX. That's present in many areas, but the long lysyl oxidase is so important because it helps in bonding. When we started looking at this lysyl oxidase, it helps especially in the keratoconus, there is a complete defect of how this lysyl oxidase is functioning. You have a genetic marker also for this, you can find it from your tears or epithelium. So what we started doing is every epithelium we take out, we used to start analyzing for the lysyl oxidase. And when we analyzed lysyl oxidase, we used to find multiple variation in the whole lysyl oxidase itself. And how does it really help you? It's just a picture showing what it really helps you is your effect of cross-linking is not the same in all the patients. You have different patients having different effects of cross-linking. That is one of the areas which is very interesting, is because the person has different locks, enzyme or gene, and that plays an important role in the outcome of this disease. Like in this case, it says that is the defect of the gene itself, and this defect can be upregulated by changing the pH of the tear film. That means the pH, the osmolality, your inflammation actually can change the entire composition of your locks, and that could cause a problem. So basically, to sum up my last slide, how your tissue behaves, that is your biomechanics of your tissue, is linked directly to your inflammation that you have in your whole eye. It starts with your tear film, epithelium, and beyond. And linking all of them actually is what is responsible for the progression of the keratoconus. The final outcome is we still don't know whether it's an inflammation, ILD, or keratoconus. But what we know is that there are a lot of unanswered questions. The whole idea of rubbing the eyes, the etiologies of atopy, or what necessarily caused the change, which one comes really first, or is there a genetic predisposition? And finally, what I'd like to say is the whole non-inflammatory component of this is a threat, because if if we try to answer this as an inflammatory pathology, then definitely we will find drugs which can actually stop this from reaching any stage where it needs any modern any treatment. Thank you. Classic is these patients who have genetic components who have a very thick cornea.
Bonus is about 3,000 patients, but it's very well documented that this 1 in 3,000 incidence jumps to about 8% when we screen patients who come for refractive surgery to us. Now, this is primarily because these patients have a notion that refractive surgery would solve their area. You see subtle signs like the post dry, Fleischer's diagram over here. You see a case of Terrier's marginal degeneration and peripheral corneal thinning. You see peripheral marginal degeneration cases of peripheral thinning over here, and obvious signs of extreme ectasia like keratoglobus. Now let's look at this particular patient. A 26-year-old female clinically normal guy, manages refraction of 1.25 with 0.75 at 175 degrees, SIN K 44.7 and 46, clinically normal looking eye, placebo image which is a perfect symmetric bow-tie pattern, but the corneal thickness is around 500 and 494. Well, with such a low refractive power, it looks like a very juicy proposition for any refractive surgery to go ahead and do a refractive surgery. But when we do the pentacam well in associated display of these patients, we immediately see a posterior ectasia over here, and this particular patient was excluded for any ablative refractive surgery. So we need to diagnose these early cases which are not picked up on slit lamp. And the conventional technology that we use is pseudocorneal topography. The classical signs are egging of Myers that you see over here, localized increase of surface power, areas of concentric decreasing power, and inferior superior dioptric asymmetry. And if we go to the quantitative criteria, the central case should be more than 47.2 diopters. R and right and left eye difference should be of keratometry reading should be more than 1 diopter, and SIN K value should be more than 45.7 diopters. Very important is SRX or skewing of the steepest radial axis. This is a very important sign of placebo-corneal analysis. If the axis of deviation of one of the heavy meridians is more than 50 degrees from the principal meridian, it's known as qualifies as the SRX pattern. Now we looked at this particular case, and we just saw a few criteria that placebo risk analysis tells us to do, but we know that this particular case would never have been picked up on placebo-corneal topography. So we need to have a technology that picks up these cases, and these cases are posterior ectasia. To speculate further, if we look at the components of keratoconus, we find that there are two components, that is corneal thinning and corneal ectasia. Corneal thinning component will have either anterior ectasia and or the posterior ectasia. So we need to know what comes first. Is it the posterior or the anterior ectasia that comes first? It's the chicken and egg question, which came first. Now let's look at the first particular case. It's a normal cornea on the left that will always be there on this side. On the right side, I will be showing you speculative conditions, like if only the anterior surface flattens out. That is the case of post-corneal ectasia. You have thinning here, but no ectasia, so it doesn't qualify as a case of corneal ectasia. A second case, we have anterior bulging, as you might see in a case of disciform keratitis, but it has an element of ectasia, but no amount of thinning at all. So it doesn't qualify in the criteria of keratoconus that we're talking about. The third condition that I'd like to show is the case of ophthalmos, where both the surfaces of the cornea, the anterior and the posterior surface, move forward and equally forward. There is no apparent discrimination between the apparent amount of movement of both the surfaces. So there is ectasia, yes, but no thinning. So it still doesn't qualify into the criteria. Now this is a very interesting condition. There is absolutely no movement of the anterior surface. You can see the posterior surface moving forward, causing a relative thinning of the cornea, yes, and an associated ectasia as well. So we'll call it a case of subclinical keratoconus. Now let's move forward. Now only if both the surfaces move forward together, and most importantly, if the posterior surface moves forward more than the anterior surface, will we actually come into the criteria of thinning, yes, and ectasia, yes. So, true keratoconus should have both the planes moving forward and the posterior surface moving more than the anterior surface. Thus, we learn from this example that both these conditions, either pre-ectatic or ectatic conditions, there is an importance of examination of the back side of the cornea. So, we must use technologies like one of the technologies that's in vogue nowadays is blind fog imaging. I will not go into the details. Now, information from this system is very intuitive. It just works like a traffic signal here. Red is abnormal, yellow is suspicious, white is normal. There is absolutely, don't be afraid seeing a map of a pentacam image. It is very intuitive. There is no need to memorize. You don't need to refer to notes for values. All the values are tagged. The reds are abnormal, the yellow is borderline, and the white is normal. Secondly, if you want to know about the system, if I want to know about ISV, all I need to go and keep my cursor of the mouse over there. It tells me about the indice. Tells me the normative values of the indice, and apart from that, we get multiple amount of data on that. We get the K values here, the corneal thickness here, the AC depth here. Apart from the choose to see. Now this is a Bellin-Ambrosio display, one of the very important tools that we use to evaluate keratoconus nowadays. We have on the left side the anterior surface analysis, on the right side the series of maps that you see is the posterior corneal analysis. This is the elevation topology of the right, anterior and the posterior side. This is the best sphere, enhanced best sphere analysis. I'll come to that later. And most importantly, the difference between the two is reflected on the last map as anterior and the posterior. And any red flagging on the map is indicative of ectasia. Just look at the values over here. These are D values. These are standard deviation values of the anterior elevation, posterior elevation, pachymetric progression, thinnest point pachymetry, and displacement of the thinnest point from the center as per two or more than two standard deviations more than normal will be flagged as red. So you have all the D values here coming into red and yellow colors. You have the dy, which is the displacement of the thinnest point, which means the thinnest point is bang on the center. And you have a statistical analysis of combination of all the 5 values as total D value. So you don't need to memorize anything when you see a map. You just have to know the values exist there for me to see, and any red flagging means subnormal. Now, what is this enhanced best sphere terminology that we use? This is very simply used to enhance our ability to screen these ectatic corneas. Now, what is done is we exclude a 4 mm zone around the most ectatic part of the cornea. All data within this zone is excluded for any further analysis. The data outside this 4 mm zone is used to calculate another best fit sphere. So this was the original best fit sphere that came up. You see the height of the nipple above the best fit sphere. It is very small as compared to the enhanced best fit sphere. So when we exclude this data, the steepest area of the cornea, and use the rest of the cornea to analyze the new best fit sphere, we are able to enhance a larger effect, a larger amount of ectasia. Our detection sensitivity increases many folds. So this is the concept of enhanced best fit sphere. The pachymetry display gives us 2 very important values. There are 22 circles actually surrounding the stencil thinnest point, and what we get is 2 points. I will not go into the details of this because of paucity of time. The corneal thickness spatial profile and the percentage increase in thickness. These are 3 lines which fall within the 2 standard deviations from normal. If your graph goes above or below the 2 standard deviations of normal, that means there is certain amount of abnormality in the pachymetry of this patient, or the corneal thickness of this patient. Now look at this amount of information it can take on a thin cornea. The cornea is 447 and minimum is in the center and minimum is 446 is the thinnest point. Yet the Bellin-Ambrosio system or the display after its enhanced ectasia analysis shows us that it's absolutely normal cornea without any ectasia, and you can see both the pachymetric graphs within that 2 standard deviation. So this is a thin cornea, but it's absolutely normal. It's not a ectatic cornea. Now there are various corneal indices that you can see: ISB, IBA, KI, CKI, IHA. No need to memorize them. Just go and see if any of the values are red flag, and in case they are, you can actually go on to the value with your mouse and it will tell you the significance of that particular index and tell you the normative values. In the refractive display, these are old things that some people use, but I just mention it for the sake of completion of the talk. Any elevation more than 8 microns of the anterior surface is considered as suspicious or abnormal, and more than 18 microns on the posterior floor or the posterior surface of the cornea is considered to be suspicious or abnormal and has to be looked into further. But I personally don't even try to remember these values. I just go to the map and everything is extremely intuitive and you can just get it at your fingertips without any problem. Now what to look in post-classic ectasias and how to analyze them. In post-classic ectasia, number 1, posterior elevation data, you can compare the pre and post-op topography if you have the posterior surface analysis, and most of the time you don't have it. And in case you don't have it, what to do? The number 1, do a refractive map screening, and on the posterior surface, if you see an area of ectasia qualitatively, and quantitatively if you see an area more than 18 microns of elevation, that should raise the suspicion index and make you think of post-classic ectasia. Or else use the Bellin-Ambrosio display. Ignore the anterior surface analysis because you've already modified the anterior surface with your ablation with LASIK and after LASIK, and ignore the pachymetric graph. All you need to do is see the elevation data on the posterior surface with the enhanced best sphere, and you can see this dB value which indicates the statistical deviation from normal, because you do not expect the posterior curvature to change after the refractive surgery. Now these are 2 new indexes that are being talked about, and especially the ART-MAX, which is the Ambrosio relational thickness maximum value. Values below 325 and 385 are suspicious, and it has a very, very high sensitivity and specificity. The progression index, which is shown on the Bellin-Ambrosio display, less than 1.2, is strongly suspicious of any list of values that we can go through. And again, I tell you, you don't need to learn any of them. I don't remember any of them by heart. You can just go to your system and find out the importance and the normative values. Thank you very much.
Thank you, Dr. Rajiv.
If I understood the question alone, it has two components. One is, if I'm just given a procedure map, how do I proceed and analyze it? It's normal.
This is for the benefit of the audience. Some of them might not be having pentagram. So what is the take on only NTF float, and what is your gold standard for screening for LASIK patients?
Placebo analysis will only give you the active corneal curvature. It has easy power around that, and equally superior accuracy is an issue. Apart from that, the values you should know is central keratometry more than 47.2 diopters, difference between right and left keratometric index of more than 1 diopter, and simulated keratometry. How do you diagnose?
Yeah, I mean not really mostly ectasia. What is your screening criteria
For any patient?
For any patient who is coming for LASIK, and what would be your screening criteria for a corneal analysis? That's
two things. Two maps I would see. One is this is the refractive map that I see, and what I would like to see is the quality of the map. Unfortunately, it's hidden somewhere behind one of the things that I put on the slide over here. But in the Q quality value, you can see the quality should not be in red or yellow, it should be white. That indicates a good image acquisition. Good image acquisition automatically gives you good results in terms of accuracy. I would like to see these indices over here. Any red flagging on the indices would make me go on to the Bellin-Ambrosio display. And as I said, look at this particular patient. We had a thin cornea, 446 diopters with thinnest point. What I would like to see is the Bellin-Ambrosio display over here, and any area that is not shown up qualitatively on the last two maps, and pachymetric maps within normal limits. Now, giving the latest theory is look at the artmax and the progression index. If these values are within normal limits, and the values for artmax, if you want to note it down, please do, because I got it from Bellin very recently. They're not available everywhere. Artmax value is 325 to 350. Anything less than 325 is a positive diagnosis for keratoconus. Anything less than 385, if you want to do a refractive surgery, you're putting the patient at a very, very high risk. So these two values, artmax values is shown to 98% and 96% specificity and sensitivity. And today is regarded one of the very important factors. And progression index. Any value more than 1.2, please don't touch that patient for refractive surgery.
Any more questions?
Sorry? Thin cornea, yes. That's beyond my talk. I think somebody else can answer what to do with that patient. But sorry.
What you have done?
So once we did the pentagram and we got all the parameters in the right places, it was absolutely normal. So just refer it back to the same.
Talking about the recent advances and the fundamentals of collagen cross-linking. Non-invasive procedure for treatment of keratoconus. So we have seen as to what is the etiology of keratoconus, and we have seen as to what is the diagnosis of keratoconus. And now once we have come to a conclusion that the patient is suffering from keratoconus, then what is the best way to go about it? So the first treatment, if it is possible, is collagen cross-linking of the cornea with riboflavin, and that is how it is called C3R or CXR. The inventors are Theo Seiler, with whom I had the opportunity to train for C3R long back, and I saw his patients, which were done almost 12 years ago when I went there in 1998. It was 2008 or 2002 somewhere, and now a long time has already passed since then, and this procedure is almost nearly 20 years now, and it's very successful treatment when done under proper indications. The history is that how this came into being is that in the 70s polymerization compounds came up in dentistry, and they were fixed by cross-linking to make the gums and the teeth harder so that they don't fall, and this was how the concept of cross-linking came into being. And we have seen that cornea becomes hardened after the treatment with corneal collagen cross-linking. And these are the two corneal buttons. One is being cross-linked up the upper one, and the other one is not cross-linked. And they are cadaver cornea, and you can appreciate the corneal hardening in these cases. The cross-linking of human cornea is a physiologic process. Stiffening of connective tissue is well known in diabetes and aging. And as we all know, the keratoconus or the ectasias of the natural ectasia or otherwise, they stop growing after the age of 30 years. So the aging process also plays a very important role in stopping the progression of ectasias. So this is one factor which is important, that the cross-linking happens with the age. Diabetes is a protection factor against keratoconus. So in diabetics, the keratoconus does not happen, or it does, even if it is there, it changes into form first. And basically during cross-linking, new chemical bonds are induced, and they make the cornea strengthened so that it does not, the keratoconus or the weakness of the cornea in the central area does not progress beyond that. And the indications for cross-linking are keratoconus, the pallid marginal degeneration, iatrogenic keratectasia, and the basic requirements are it has to be progressive. So we have to document that the patient cornea is progressing and getting worsened over a period of time at an interval of at least 6 months. The corneal thickness at the thinnest location is more than 400 micron, and that is the most important fact. And maximum corneal curvature is less than 60 diopters, so it cannot be done for very, very steep corneas where the possibility of other damages are very high. Incidence of keratoconus is 0.05% of the population, which is pretty high, and there are no firm data available on iatrogenic keratectasia. But since the advent of new machines like Pentacam, we have come across much more patients of keratectasia, iatrogenic keratectasia, compared to what we were seeing say 15 years ago. Goals of the cross-linking treatment is to stabilize the cornea and to stop the progression. And as soon as a significant progression of the ectasia or the corneal thinning is discovered, this is the time for the treatment. Though it stops at a later point in time in the advancing age like 35 or so, but still if it is a progressing, then probably we have to do it at that age also. Which diagnostic tools can be used to rate the efficacy of the treatment? As the earlier speakers have talked, the topography, the best corrected visual acuity, the corneal thickness, and slit lamp examination of the keratoconus level and classification. These are few things which can guide you. And the cross-linking, as it is done with the patient lying horizontally, and the beam is falling vertically, about 50 millimeter away from the eye, and it has to be very homogeneous. So, and the treatment steps are: we put local anesthesia, and after local anesthesia, let the patient lie down on the table, and then manual de-epithelialization of 8 to 9 millimeter of circle, and then riboflavin solution. And we will talk about the riboflavin solution later, but this is the basic initial steps of riboflavin that we started with. Riboflavin solution is put every 3 minutes for approximately 30 minutes, and then after 30 minutes you observe clear fluorescence within the antechamber. Ask the patient to sit on the slit lamp and observe, and you can see that there is riboflavin in the aqueous. After that, you irradiate the patient. You put the riboflavin and then irradiate the patient with the ultraviolet. And during irradiation with the ultraviolet light, drop riboflavin solution every 5 minutes, keep on dropping, and every 2 minutes put VSS with the riboflavin so that the cornea is moistened, and also the riboflavin is spread all across the cornea in a uniform layer. treatment has to be visually controlled, and you keep on seeing that the distance, the focusing, the eye centration is very good, because if you expose the limbus for a long time, there is damage to the limbal cells. So you don't want to have the corneal limbus exposed to ultraviolet. Only the central 8 millimeter or wherever the maximum cone is there you want to expose, and do not expose the limbus, especially take care of that. And sometimes the patient has discomfort for a long time, 30 minutes. So if the patient has a discomfort, then probably you have to adjust the light again and again. But in any case, you have to do it. Now choose the wavelength, and we know that we tried, the experiments were done, and with the smaller wavelength, the photoconjunctivitis was there, and there was high absorption of DNA. And with a longer wavelength, there was blue light damage. So the best wavelength was 360, 370, and there is high transmission of DNA. Now, just to update on the ectasia, starts usually in the second decades of life, and this has been taken earlier. How much UV light gets into the eye? This is again a very important factor, and the light which goes into the eye is very little as compared to the threshold. As you see, the threshold for retina is 7.7 joules per square centimeter. The amount of light which goes into reaching up to the retina is only 0.12. And similarly, at the endothelium, the damaging light is about 0.65, and what is reaching there is less than 0.46 or something of that sort. So the ultraviolet light does not reach in any damaging concentration after you have put the riboflavin on the surface of the cornea, and it is absorbed up to the anterior chamber. So this is the safety, and that is why we keep a thickness of at least 400 micron, because at 400 micron only 6% of the light is reaching there, which is approximately 0.18 milliwatt per square centimeter, which is hardly any damage to the endothelial cells if they are at 400 microns. So this is what it is, and then and also in treated cornea and untreated cornea, the treated cornea can withstand the pressure tension and it becomes hardened, as you can see in this graph, which is the tension in PA is very high to stretch the cornea to a certain extent. In confocal microscopy, it has been studied, and in all the cases, the stromal cells, the cells grow in about 6 months completely. They actually initially the cross-linking keratocytes 300 micron, and then the repopulation or regeneration of these cells takes about 6 months, and after 6 months the keratocytes are completely regenerated. So the quality of corneal cells and corneal structure is maintained after that. And similarly, 6 months post-op, the corneal edema is reduced and corneal regular endothelium becomes absolutely regular. Initially, in all cases of cross-linking, there is some amount of corneal edema, but at a later point in time, there is some amount of corneal thinning which happens after cross-linking. So in all the cases of corneal collagen cross-linking, a progressive keratoconus can be transferred into a compressed keratoconus by means of a collagen cross-linking. And what has recently changed in the corneal collagen cross-linking there are machines which give us possibility of accelerated cross-linking, the LASIK extra, the riboflavin, which has changed from coming into the Dextran to DSS, and then transepithelial cross-linking, which is which has come recently in last 2-3 years. In the conventional cross-linking, the total energy is 90 milliwatt over a period of 30 minutes. 30-minute exposure time is uncomfortable to the patient, so to reduce the exposure time, a higher energy ultraviolet light can be used, and so we can use similar amount of energy in 10 minutes by in 9 minutes by using a 10 milliwatt energy, and similarly 15 milliwatt for 6 minutes and 18 milliwatt watts for 5 minutes. And it is seen that a 15 milliwatt or 18 milliwatt for 5 minutes is a decent, because after using more than 18 milliwatt there is some damage to the cornea and there is an endothelial edema which persists. So ideally 18 milliwatt into 5 minutes is a good time for accelerated cross-linking. And LASIK extra is another procedure where in high risk cases or in hyperopia you want to do LASIK, and there is a possibility of post LASIK ectasia. After the flap plus laser treatment, riboflavin without Dextran, of course, it is in BSS, is put on the bed and flap replaced for 1 minute. So the riboflavin absorbs above and below, under the flap and over the flap, and this absorbs very quickly in 1 minute. More than 300 to 400 microns of the cornea absorbs riboflavin, and then with the flap on, the UV exposure is done for 30 milliwatt into 1 minute only. It's a very small, short, we are not giving a 90 milliwatt kind of time, 90 milliwatt kind of exposure. It is only 30 milliwatt for 1 minute, and then the riboflavin is washed from the interface. And this gives excellent results in the sense that in all those cases which are high risk, high myopes, or in cases where there is a possibility of ectasia development, or you are seeing that there is an NTF road changes but definitely not posterior road changes, these cases do not go into the ectasia after the procedure. This gives strength to the cornea and reduces the possibility of ectasia, and also in cases of hyperopic correction, the regression is less after doing LASIK extra, because biomechanical changes strengthen the ablated mid-peripheral cornea and query ectasia of the area is prevented, because mid-peripheral cornea is the culprit of the ectasia development that has been shown in this study. Riboflavin normally was, we were using riboflavin which was for in 20% dextran, but we have used riboflavin water for injection also. And in these cases, why we use water for injection is we use a hypotonic riboflavin in cases where the corneal thickness is less than 400 but more than 350. And in all these cases, when we put the riboflavin in the water for injection, the cornea swells to 400 microns in about a minute or two, and then we can continue with BSS and alternately with water for injection riboflavin or distilled water. And in these cases, the cornea is maintained at 400 microns for the treatment of with the ultraviolet, and that is possible for up to 350 micron in cornea, but we should not go anything less than 350 in any case. The most recent development is the riboflavin, which is available in BSS, and in BSS the corneal edema is much less, the absorption is much better, and also the riboflavin crosses into the anterior chamber and through the cornea much faster and much smoothly and uniformly. So this new riboflavin which has come in BSS is the way to go. Dextran was more appropriate for bovine corneas, but it has been seen that in BSS, in human corneas, the BSS riboflavin works better. Now, transepithelial cross-linking is, of course, when you are not abrading the cornea, it is comfortable for the patients and also is better for the pediatric group and for thinner corneas. But the efficacy is only 1/5, so it is only 20% efficacious in treatments, and in majority of my cases where I have done the transepithelial cross-linking, I have not been very satisfied. So personally, I did transepithelial cross-linking in some cases, but later on realized that this is not the way to go, and I am not doing the transepithelial cross-linking anymore. I continue with the normal cross-linking after abrading the cornea in the 8 or 9 millimeter central area. Thank you very much. Any questions on cross-linking? Because we have 2 more speakers. Dr. Rishi Mohan is here, and so we are here, so we can take the next talk. Any questions on cross-linking?
Do you use alcohol to do epithelium or you scrape them?
I scrape the epithelium.